Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on the pulmonary infections of the immunocompromised patient, we are going to be talking about Aspergillus infection today. So Aspergillus is a soil fungus and it manifests as 5 distinct categories of pulmonary disease. Now it only affects those who have abnormal immunity or they have some pre-existing pulmonary disease, and depending on the kind of pre-existing disease they have, that's what will determine the category of disease that you would see. So the patient may be asthmatic, may be immunocompromised, may have some prior infection or some structural or congenital abnormalities. Any of these will determine what kind of Aspergillus manifestation the patient will present with. So the first category we'll talk about is allergic bronchopulmonary aspergillosis, and this is a hypersensitivity reaction. That means it's an allergic reaction to the Aspergillus fungus, and it's commonly seen in patients who have long-standing asthma. So that is to say that allergic bronchopulmonary aspergillosis is not an infection. So these patients would clinically present with recurrent wheezing, low-grade fever, cough, some sputum production, which would contain fragments of the Aspergillus hyphae within it. And to diagnose, it makes sense that it will be diagnosed using serum testing for this Aspergillus IgE antibody. The key finding on CT is central bronchiectasis and mucoid impaction. And this mucoid impaction can be seen as high attenuation or even calcified. So when you have this combination of calcified or high attenuation mucoid impaction within a bronchiectatic airway, it represents what we call the finger in glove sign. So this CT honed into the right lung shows dense bronchial mucoid impaction representing the finger in glove sign. So you can see these dilated bronchi, and within these bronchi we have this high attenuation material inside it. And I don't know about you, but this looks like a gloved hand to me. So this is the finger in glove sign of allergic bronchopulmonary aspergillosis. Then we move on to the next category of finding, and that is the saprophytic aspergillosis or aspergilloma. So remember we said that the first one, allergic bronchopulmonary aspergillosis, occurs in the context of chronic asthma. In this case, it occurs in the context of a pre-existing cavity within the lung. So this aspergilloma or saprophytic aspergillosis is a conglomeration of intertwined Aspergillus fungal hyphae and cellular debris, which forms a mycetoma or what we call a fungal ball. So this forms within a pre-existing cavity. So this fungal ball is actually mobile, and when you are shifting the patient from left to right during imaging, you realize that this fungal ball would also be shifting within the cavity with different positions. The most common causes of a pre-existing cavity, as we can guess, would be prior TB infection and sarcoidosis. Less commonly, you may have some congenital anomalies like bronchogenic cysts or sequestration, and even some pneumatoceles, which could be post-infectious or post-traumatic, creating these cavities that the fungal balls can then form within. Now, hemoptysis is the most common symptom of aspergilloma if ever it decides to be symptomatic. And for this to be treated, you would have to embolize or resect the aspergilloma with its cavity rather than just giving antifungal medications. Now, when you see a crescent of air around the mycetoma separating it from the wall of the cavity, the correct term that is used to describe this is the monod sign, not the air crescent sign. The air crescent sign would come to see later on. It's actually reserved for another category of aspergillosis. That's the angioinvasive form of aspergillosis. We'll come to see that one later on. So this CT scan of the chest shows an irregular opacity resting dependent within a left upper lobe cavity, and this represents the aspergilloma. The mono sign is the curvilinear air surrounding the aspergilloma. Now, this patient was known to have prior TB with biapical scarring and a left apical cavity where the aspergilloma came to sit. Now, the third category is semi-invasive aspergillosis or chronic necrotizing aspergillosis, and this is a necrotizing granulomatous inflammation similar to post-primary TB in its pathology, and this is in response to chronic aspergillus infection. Semi-invasive aspergillosis is seen in debilitated, diabetic, alcoholic, and COPD patients. Its clinical symptoms include cough, chronic fever, and less commonly hemoptysis. So on CT, there are segmental areas of consolidation, often with cavitation. So while in the fungal ball, there is a pre-existing cavity that came about due to some prior TB or sarcoid infection. In this case, there is a granulomatous inflammatory condition that comes about as a result of the aspergillus infection, and this becomes necrotic and then creates its own cavity. And you may also have pleural thickening, which progresses slowly over months or years. So this image actually is of a 53-year-old man with semi-invasive pulmonary aspergillosis and a history of diabetes and pulmonary emphysema. So this CT scan obtained at the level of the aortic arch here shows an area of consolidation and surrounding ground glass opacity in the left upper lobe, and it seems to have started cavitating here, and this was a case of semi-invasive pulmonary aspergillosis. We can see the background emphysema here as this area of lung appears quite dark compared to this area and this area, which is the normal lung. So this is the emphysematous lung. Then the fourth category is airway invasive aspergillosis. Now, airway invasive aspergillosis is aspergillus infection that has gone deep to the epithelial cells of the airway. So it invades the epithelial cells up to the level of the basement membrane. So it is seen only in immunocompromised patients like neutropenic patients and AIDS patients. Now, the spectrum of clinical disease for airway invasive aspergillosis ranges from bronchiolitis to bronchopneumonia. I mean, as the name implies, it is airway invasive, so it's the airways that are involved. So bronchiolitis, bronchopneumonia, and it also makes sense that the CT findings for airway invasive aspergillosis would include airway-related stuff like centrilobular nodules, tree in bud nodules, which represent endobronchial spread of disease. And if bronchopneumonia is present, the radiograph and CT findings really are not distinguishable from other causes of bronchopneumonia like staph aureus. So in this image, it's a CT scan of the chest, and it shows bilateral patchy bronchocentric consolidation with ground glass halos. And this was confirmed to be a case of airway invasive aspergillosis. Without good history and without other laboratory findings, we may have just made a diagnosis of bronchopneumonia. Finally, the final category we'll talk about is angioinvasive aspergillosis. And this is an aggressive infection and is characterized by invasion and occlusion of arterioles and smaller pulmonary arteries by the fungal hyphae. Now, while the airway invasive ended at the basement membrane, angioinvasive goes beyond the basement membrane and now invades the blood vessels, the small blood vessels below the basement membrane, hence the name angioinvasive. It's seen almost exclusively in neutropenic patients. And one of the signs to note is the CT halo sign, which represents a halo of ground glass attenuation surrounding an area of consolidation. Now, this halo of ground glass attenuation corresponds to hemorrhage, which also makes sense since microvasculature are involved in angioinvasive aspergillosis. The halo sign is not necessarily specific to angioinvasive aspergillosis, since it can be seen in other conditions like viral infections, granulomatosis with polyangiitis, Kaposi sarcoma. Some hemorrhagic metastasis can also present with the halo sign, among others. Now, there's another sign, the air crescent sign, which we mentioned earlier when we were talking about aspergilloma. But we mentioned that the term monod sign is preferred for aspergilloma. Now, air crescent sign is the preferred term when we are talking about angioinvasive aspergillosis, and this represents a crescent of air from retraction of the infarcted lung. Now, this occurs when the patient's neutrophil count starts going up. We mentioned that this condition occurs when the patient is neutropenic, but when the patient's neutrophil count starts going up and the person is getting better, the infarcted lung retracts and creates this crescent of air, and that's called the air crescent sign. And it's actually a good prognostic sign, as it indicates that the patient is in a recovery phase. So in this image, it shows the halo sign, and we see in the left upper lobe there is this mass with peripheral ground glass opacity, representing pulmonary hemorrhage in a case of angioinvasive aspergillosis. And in this CT coned in to the left lower lobe, it shows a crescent-shaped air collection anterior to the opacity, which is the crescent sign of angioinvasive aspergillosis. So to put it all together, we mentioned that there are 5 spectrum of disease of pulmonary aspergillosis. Allergic bronchopulmonary aspergillosis occurs in patients who have chronic asthma or cystic fibrosis, and it shows the finger in glove sign. Aspergilloma or mycetoma would be present in patients who have a pre-existing cavity like prior TB or prior sarcoid, and you have a mobile mycetoma, and it shows the monod sign. Then in patients who have some chronic lung disease like emphysema, you have a semi-invasive type of aspergillus infection where we see chronic consolidation which cavitates, similar to post-primary TB. Then under the invasive diseases seen in the immunocompromised, we have the airway invasive disease, which looks like bronchopneumonia with centrilobular nodules and Trey-Bad nodules, and the angioinvasive disease, which shows us the halo sign and the air crescent sign. Thank you very much for your attention. I hope this has been very helpful. If it has been helpful to you, kindly like it, share a comment, share it to someone you think would also appreciate this. Our next topic would be on pulmonary edema. Thank you very much, and I will see you in the next